Test, test. There we go. Good evening. I'm Addie Gasper, nurse practitioner at the Neurology Movement Disorder Clinic at UW Health. And it's my honor to introduce you to Caitlin Krager-Cook.
Close.
Oh, shoot, I'm so sorry. Anyway, she comes from the UW Voice and Swallow Clinic and will be talking to you about voice and speech issues in Parkinson's tonight.
Are you able to hear me okay? Okay. Hello, I am Caitlin, as Addie said. So I'm a speech pathologist, also known as a speech therapist. It's the same thing, in case you were wondering. I work in actually the Ear, Nose, and Throat Clinic, also known as the Voice and Swallow Clinic at UW Hospital. I'm one of many speech pathologists, and we all are very specialized in our different ways, which I'm going to get into, so that you know if you have a specific concern, you know kind of where to turn. Today we're going to focus our talk on the voice and the speech as it relates to Parkinson's disease and Parkinsonian disorders. But speech pathologists actually do quite a lot of things in relation to neurological diseases. So I want to kind of go through that a little bit first. And I don't know what happened here. Okay. So as one of the members of the team of caregivers working with somebody who has Parkinson's disease, we have several roles as speech pathologists. First of all is the swallowing. And I think one of my colleagues, Michelle Chucci, was here last year talking a little bit more about swallowing and some of the research she's doing in that area. But that also will involve chewing, and then saliva control is a big deal when it comes to Parkinsonian diseases. So we work with that as well in therapy. Today, what we're going to talk about specifically are voice and then speech and the way that you express yourself. And finally, one of the things that we also work on is cognition and language skills. So we're kind of all over the board. If it's above the throat, we're taking care of it. So I'm not going to press that button again. I don't want it to go black. Okay, so let's talk about communication and speaking. What does it involve? First and foremost, respiration, so breathing. To be able to create a voice and to get the energy for speech, you need to be able to breathe. You need to have breath support. This is a very important piece when it comes to Parkinson's disease, so we're going to come back to this. The next thing we need is phonation. In humans, that's the vocal cords. That's the voice. So the air moves through the lungs, through the vocal cords, and that's when mechanical sound is created. Then it's what we call articulation, and that's actually our tongue and our lips and the surfaces in our mouth and in the back of our throat creating the sounds that are the speech sounds. Resonance is the way, essentially, that the sound bounces around inside our tissues and inside our cavities in our head and our mouth to create the sound that comes out. A little fun fact for you, if you put a microphone up at the vocal cords, all you would really hear is a little buzz. So the actual sound that comes out of your mouth is the sound that is filtered through your throat and your nose and your mouth and the tissues in those areas to create your unique voice. So, prosody and intonation. This is something that can very much be affected when you have Parkinson's disease. Your ability to change pitches and change your intonation, as well as kind of making your sentences sound, for example, like a question when you raise your voice, or like a statement when you lower your voice. This can become more difficult to control with Parkinson's disease. And then finally, what we call the suprasegmental characteristics, which are gestures, facial expressions, all of those extra things that make communication and supplement our speech to really communicate the intended message of what we want to say. And this is certainly something that's affected as well in Parkinson's disease. So now knowing kind of the basics of speech, what do we typically see in Parkinson's disease? Both in the aspect of speech and in the aspect of voice. So typically, what we are looking for is short rushes of speech. So talk really fast so you don't run out of air. Or the speech is really, really slow because you don't have enough air. Imprecise speech, mumbled speech, decreased articulation. Sometimes people have these word repetitions or sound repetitions, almost like a stutter, and it can be kind of tick-like. And then talking about those prosodic features again, a masked face or the stiff face, which can really affect your ability not only to communicate your intended emotion or feeling with whatever you're trying to say, but can also get in the way of the actual movements to create the sounds. When it comes to voice, the number one hallmark characteristic, and sometimes the very first thing that you notice with symptomology of Parkinson's disease is this quiet voice. That seems to be the biggest complaint that we hear from patients, and it's the biggest thing that we want to treat. So going along with that, difficulty projecting your voice, breathy voice, or you easily run out of air when you're talking. A hoarse voice is often one of the hallmark characteristics, one of the things we see at first, sometimes even a harsh voice. And then monotone voice, so that inability to change your pitch, which can really, again, affect a listener's understanding of what it is that you want to communicate. So this kind of fits in pretty well with what we know about Parkinson's disease as it affects all of the rest of the body, right? The bradykinesia, which is those slow movements, the rigidity, so inability to kind of move the muscles or structures quite as well, tremor, and then ability to initiate your movements. The movements required for speech are so precise and so fine that that initiation piece can really get in the way sometimes. Okay. So if you were to come into the clinic with a diagnosis of Parkinson's disease, we really want to take a look, of course, at you as a whole person, but specifically at your speech and at your voice to be able to figure out, okay, what is this person capable of doing right now, and where are the deficiencies? Where are things a little bit more difficult at this time? So that we can figure out what we need to do to help you make things a little bit better. So first of all, how clear is your speech? And in parentheses, I wrote how severe is the dysarthria? Dysarthria meaning unclear speech. So is your voice clear? Is your speech clear? And if it's not, how severely impaired is that unclear speech? How understandable are you to other people as they're listening? And it works really well for us, if we've never met you, to be able to say, well, for an unfamiliar listener, this is how understandable this person is. We want to know how fast you're talking, how fast you're able to talk and produce sounds consecutively. We also want to know how fluent your speech is. So stuttering, as I mentioned earlier, can be a characteristic of Parkinsonism, and so we want to make sure that you do have fluent speech, or if you don't, we need to figure out kind of what is being repeated. Is it sounds? Is it words? Is it something else altogether? We want to know how loud your speech is. Again, going back to that number one complaint, the voice is quiet. We measure that with acoustic measures, with aerodynamic measures. We want to see in decibels, how much are you currently producing, and then how much are you able to produce? And we have equipment that can measure that. We want to know about your breathing. So if breathing is the power source for creating a voice and creating speech, we need to know what you're able to do with that power source. We need to know if you have the capacity to take bigger breaths and how well you can control those breaths as you're exhaling, because speech occurs as we exhale. And then we want to know kind of how coordinated, in addition to that, your breathing is with your voicing. And we have ways to measure that as well. Are you able to vary your intonation, and how variable is your intonation? And we test that both just by talking to you in general conversation and by doing some formal testing so we can compare it to normative data. We also want to know what your pitch range is. So we want to know how high your voice can go and how low your voice can go. That gives us good information about what we kind of have to work with as we do therapy with you and help you to improve the speech. We want to know how you're able to, how your muscles are working in your face and in your throat. So what is the range of motion of the muscles? How stiff is everything? How rigid is everything? And we want to know kind of the ability of those muscles to move, the stimulability of them to move. And then finally, what is your resonance sounding like? So there's different ways to describe resonance. It can be nasal, like if you've ever had a cold, it sounds really hyponasal, we call that. It could be stuck in your throat. It could be forward resonance that comes out here like an opera singer. So we want to look at that too, because that is something that we can use to our advantage to help you get a stronger, clearer speech and voice. Okay, so when it comes to looking at the voice, so we talked about speech and the way that you talk. But the other piece that we want to look at is the actual voice at the level of the vocal cords. So we can't just do that by looking. Obviously, we don't have X-ray vision. So we need to actually take a scope and get inside your throat and look at how your vocal cords are working when they're moving and vibrating. But we also want to see just kind of what they're looking like structurally and anatomically. So if you are having issues with your voice, which we kind of outlined earlier, so particularly that quiet voice, but if you have a hoarse voice, if you're noticing a harsh voice, any of those would be reasons to come get an exam, and we would want you to see a speech pathologist who specializes in the voice. That's me. As we discussed, speech pathologists do lots of different things, and at UW Health we have kind of a unique model, which is not the same at most medical centers or hospitals, in which there are speech pathologists who just work with voice disorders, there are speech pathologists who just work with swallowing disorders, and then there are speech pathologists who just work with communication and cognitive disorders. So we're very separated, but that means we are very specialized, and we're able to really do everything we need to in our specific area and have everything available to us that we need. So us voice specialist clinicians are located in the same office as the ear, nose, and throat doctors because we work together with them and do all our assessments together with them, specifically with two doctors who are trained in the vocal cords only, laryngologists. So whether you come to UW Health or not, what I would recommend is that you get a voice-trained speech pathologist to do that assessment for you, because it does take specialized training and you gotta know what you're looking for. And to be able to do the exam takes some training as well. So if you go to get your voice assessed, you should make sure that either the doctor, the ear, nose, and throat doctor, or the speech pathologist that you're treating, that is working with you, takes a look at your vocal cords and does video stroboscopy, which I'm going to show you in just a moment here. Okay, so these are the vocal cords, and I show these to people every day, and I get a lot of comments about how gross they are, so I apologize if I'm grossing you out a little bit. But the top two, actually, you can see that this one's kind of dark over here on the left, but that's the vocal cords as they're open. And this is the vocal cords as they're closed. So when they're open so that air can move through and we can breathe. When they're closed, they're actually vibrating against each other to create a voice. So these two guys up here are from a normal, healthy person. They're actually my vocal cords, if you want to know. I brought a picture for you to see. And then these are from somebody who has Parkinson's disease that we treated several years ago. And the difference is, now that there's a little bit of a difference in the color, but what you can see is that the vocal cords here are a little bit thinner. They're lacking the bulk and kind of the firmness of the vocal cords up here. And then the other piece is when they go to close to create a voice, they're not completely closing. You can see there's a little hole, there's a little slit right in there. And if there's a little slit in there, it means you're going to have a quieter voice and a breathier voice, and possibly a hoarser voice because you're losing air as you're speaking. And so it's a less efficient voice. And this is a very common picture that we see in people who do have Parkinson's disease or any type of Parkinsonian disorder. And I should tell you, as long as we're looking at this, that we do have the vocal cords right here, and then in there, in that hole, that's the trachea down to the lungs. That's the airway. So the vocal cords sit at the very top of the airway. They're basically the last level of protection so that you don't choke. So when something goes down the wrong pipe, as has happened to all of us, this is where it goes. It goes down this way. The right pipe is back there somewhere. I'm too zoomed in for you to see it right now, but or whoever took that is. But the vocal cords will close so that thing that started to go down the wrong pipe can't get down any further. And then they'll hit each other like this really, really hard to fling that thing back out. And that's how they protect the airway. It's really simple when you think about it, but it's also pretty complicated. Yeah. So obviously our talk today is not about swallowing, but I would be happy to talk to you more about that if you're interested later. Okay. So then the other piece, when you come into our clinic and we're taking a look at how your voice is functioning and your speech is functioning, we want to know, are you stimulable for therapy? Meaning, would you benefit from therapy? If we do speech therapy tasks with you, is your body responding in a way that tells us that therapy will be successful for you? So, are you able to vary your loudness and your pitch if we give you different cues and facilitators? Can you use more strength to produce certain sounds like puzz and does and cuz if we give you some cues as to how to do it with more strength? And if you can produce it with more strength, how long does that last before those muscles poop out? Are you able to take bigger breaths? And then as you're exhaling, are you able to control that exhalation a little bit? So these are some of the things that we're going to test, and it doesn't take more than a couple of minutes during our evaluation, often when we have that scope in the throat and we're looking, to see so we can kind of predict and prognosticate, yes, this person will be successful with speech therapy, or no, this might not be the best course of action right now, let's explore something else. Okay, and the other thing that we always want to know as clinicians, as therapists, and I think any other medical clinician would agree with this, what do you want from this? What can we do to help you function in your everyday life? So, what does your personal communication look like day to day? What are you using your speech for? And if you're not using speech all the time, what other things are you using? Are you emailing? Are you texting? Are you writing letters? Who are you currently communicating with? Who are your primary communication partners? And then, where are you speaking to these people? Is it primarily at a home setting where it's quiet and you don't have any background noise? Is it a lot of times in restaurants where it's really, really loud and you have a lot of stuff to talk over and might also be contending with trying to eat and swallow and use your energy for talking? Is it grandkids where you're probably going to have to be using a little bit more energy overall to be interacting with them? So what is going well with your communication and what is not going well? And what would you like to see as far as change in the way you're communicating? And then generally just, are you communicating? What is your communication participation level in life? Are you not communicating so much because it's a lot of work? Have you kind of isolated yourself more because communication is tough or because people have said repeatedly that they don't understand you? We want to know those things because it really makes a difference. And maybe that's the case and it doesn't matter to you. Maybe you like to just kind of be home alone. So then it's not a problem. But if it's something that bothers you, then we want to make sure we can help you with that. The other thing that we'll ask you about is your primary communication partner or partners, because we want to know what are some of the things that they're noticing that they do to help you in your communication, either with the way you're understanding them or the way that they're understanding you. And then are they available to be part of the therapy so we can have them help to support what we're doing in therapy? It would make sense that the people you talk to most should know some of the things you're learning in therapy so that they can kind of carry those things over into everyday life with you. So I told you that we do test when a patient comes in wanting a speech and voice evaluation. We do check to see kind of how they might respond to therapy facilitators. And obviously we don't have a crystal ball. We can't know for sure what's going to happen, but we can say, you know, with our experience and with what the research says, who will benefit the most from speech and voice therapy. And the research says that patients with the best outcomes have the following characteristics. Number one, they are intrinsically motivated. So like I just said, if it's not a problem for you that you talk quieter because you're not really interested in talking to people that much, then maybe you don't need therapy and maybe it wouldn't be that beneficial, at least at this time. Are you in a place where you are cognitively able to learn a new technique? So this kind of speaks a little bit to some of the cognitive changes that may occur in memory changes with Parkinson's disease, but it also speaks to what else is going on in your life that might be demanding the attention of your cognition. You know, are you having major medical issues right now? Do you have a family member who's needing your assistance more than usual right now? Or are you dealing with some other kind of stressor? We would want to know that. To be able to tell whether you'd be a good fit for therapy and benefit well. Do you have the energy to practice intensively? And then this is where we want to make sure you're working carefully and closely with your doctor to making sure that the medications are at the level that they should be. And we want to look at timing of medications, and we want to look at how long they're being effective for you and other times when they're not effective. And we would kind of want to plan our therapy around that. So as we talked about, we want to know that you showed some ability to change in our therapy practice techniques. And then we want to know that you have realistic expectations. So do you understand kind of what we can do for you and what our limitations are as therapists, given the way that this disease can work? Okay, so Parkinson's disease, as we all know, is kind of a disease that takes a longer course over time. So how do you know when the right time is to seek treatment for speech therapy, at least? So a couple of questions you can ask yourself. How are you feeling about your current speaking and communication level? You know, I was reading some studies in preparation for this, and there was a really nice study that I read that just kind of talked to patients about their viewpoints on therapy. This was a good quote that I read. The patient said, "I didn't want to go to therapy, and then I realized I was waiting till the meds kicked in to even start speaking for the day. And that's when I realized I needed to go to therapy." Well, that makes a whole lot of sense. So is that the situation that you're in, and does it bother you? Are you noticing that it's really tiring or fatiguing to speak? Probably for everyone in the room, once in a while, it takes some effort to speak and to get your voice out, but is that happening all the time? Is it happening more frequently? If so, it might be time to seek some services. And then how frustrated do you get if people are saying to you, "I can't hear you," or "speak up," or "repeat yourself"? Does that bother you? If it does, or if you're hearing it more and more and more, it might be time to seek services. As I'm going to get into shortly, typically therapy for speech therapy and voice therapy for Parkinson's disease is intensive. So do you have the time and the energy to put into participating in an intensive program? And then the other piece is, do you have the cognitive energy to, as you're learning these new techniques, be able to not only think about what you're saying as you're going through your everyday conversations, as we all do, but also to think about how you're saying it. So really applying these newly learned techniques to your speaking all of the time. It takes a lot of work, especially at first. And obviously we give you support and we help you through that, but you have to be ready to kind of manage both of those things simultaneously for a little while until it becomes a little bit more of a natural thing for you. So these are some of the things I would say you should consider. There's other factors too, obviously, but so getting into therapy, what are our primary goals for speech and voice therapy? Number one, volume. We want to increase the volume. And research has shown that if we can increase that volume, it'll actually increase other things. It'll increase the muscle movements, those fine motor movements in the mouth and in the tongue. It will increase your ability to move around your intonation. So it will increase your breaths. You'll take bigger breaths, which is something that we always want. So volume is big. We want to increase your pitch range, and then we want to increase your ability to be understood, or your intelligibility. That's what I do in the voice clinic as a voice clinician. But all of these other things, all of these things, are other things that the speech pathologist may need to work on. And I will tell you, first and foremost, swallowing is kind of our number one priority as speech pathologists because that really affects your safety. So we need to make sure that that is dealt with before we would get to anything else. But as long as swallowing is in a good place, then we will work on those three things above. We will talk about saliva management. We might work on language and cognition. Language is different than speech. If you think about language is kind of formulating the words and thinking about what you want to say. Speech is producing the words. But obviously they work hand in hand and they need to be addressed separately in some brains. And then we would work on some of those extra features like the facial expressions, like your prosody and your ability to kind of make sentences flow and sound natural. So we would definitely want to make sure we sit down and prioritize what is most important for you from the standpoint of speech and language and swallow and cognition and saliva control and voice. Okay, so I just wanted to kind of talk a little bit about common treatment programs that we use. If you were to kind of do a Google search about speech therapy and Parkinson's disease, these are some of the things that would come up. And of course, I have to just make the comment that I don't endorse any of these. I just want to kind of let you know what is available. So the number one thing that you will have heard about or would hear about if you start to investigate this is this Lee Silverman Voice Treatment Program, LSVT. LSVT Loud, and there's also an LSVT Big, which I'm going to talk more about in a moment. There's the Speak Out Treatment Program. There's this thing called pitch limiting voice therapy, and then expiratory muscle strength training. These are 4 programs that I specifically listed because there is evidence to support all of these in the research literature. There are other methods too, which I will talk about shortly, but these are kind of the big ones. So I wanted to make sure that I was explaining this objectively and correctly, so I went ahead and just took some quotes right from the websites of these programs. So LSVT Loud trains people with Parkinson's disease to use their voice at a more normal loudness level while speaking in anywhere that they speak. Key to the treatment is helping people recalibrate their perceptions so they know how loud or soft they sound to other people and can feel more comfortable using a stronger voice at a normal loudness level. So one thing that we hear a lot, I told you that our goal for therapy is often to work on loudness, And one thing that our patients tell us a lot is, you're telling me to talk louder, but I feel like I'm shouting. So we have to recalibrate that ear a little bit. Often what happens is our patients have been living with their voice for so long, and it's been such a slow decline to that softer voice level that you don't even realize there's been a change. So we have to kind of recalibrate your ear, and we use that by using a sound level meter, and by just giving feedback and kind of practicing louder and softer and getting comfortable with a new feeling. So Lee Silverman Voice Treatment Program definitely capitalizes on that whole idea. So Lee Silverman, in case you were wondering, by the way, is a woman who had Parkinson's disease back, I think, around 1990. And there's a speech pathologist who's out west, I think Colorado, who created this program and named it after this patient who was obviously very influential to her. There's been a lot of research done to show that this is a very effective and successful program. It is an intensive therapy program, so typically the course looks like 4 weeks with 4 one-hour sessions per day. And then you have to practice once on your own every day too. And on the days you don't have therapy, you have to practice twice. So it's pretty intensive. But that's what makes it work, according to the people who created it. Lee Silverman Voice Treatment Program is something that a speech pathologist has to be certified to be able to administer. So you might want to check on that with whatever speech pathologist that you're working with. Not every speech pathologist is certified in it, but it is not rocket science, and so a lot of speech pathologists can figure out how to do it without the certification. And then some rehab centers do offer this program together with the LSVT BIG program, which is run by physical therapists, along the same lines of thinking big with your movements and big with your sounds. So it's a pretty cool program. It was certainly groundbreaking when it first came out. Now, Speak Out is newer in the game, probably within the last 7, 8 years or so. And from their website, the primary goals of Speak Out are to strengthen the muscles used for speaking and swallowing, and to teach patients how to speak with intent. So speaking with intent, speaking loudly, as you can see, not hugely different between these two programs. The approaches are just slightly different. This program generally contains 12 individual speech therapy sessions, and you can kind of decide between the clinician and the patient across how many weeks you want this to go. And it's actually a workbook that they send you, and you go through this workbook, and it targets both speech and your voice, and it also targets some memory. So it's a little more inclusive. And then after these 12 initial sessions with the speech pathologist, you go and join what they call the Loud Crowd, which is basically group therapy for your speech and your voice, and a little bit of memory too. And it's just to maintain this new, bigger way of talking that you've developed. And they do include singing. So if you've heard of choirs for people with Parkinson's disease, the tremble clefs, things like that, that's kind of along these lines. Singing is actually a really good way to kind of get that breath support and get that power to practice loudness. This is another program that requires a speech pathologist to be trained and certified. The difference between this program and LSVT is that this one is a not-for-profit, LSVT is for-profit, so that might make a difference to you. I know that in some of the speech pathology forums that I'm a part of, people feel very passionately about this, one way or the other, so it's just worth knowing. And then some other therapy things that we might use that maybe there's a little bit less research evidence on, but to be perfectly honest with you, we don't have a whole ton of evidence for a lot of things that we do in speech therapy yet. We're just starting to get more into the research game and really proving that what we do makes a difference. So at least from the therapy standpoint. So pacing boards and other pacing methods, such as using a metronome to kind of make sure that you're not rushing your speech or you're not too slow with your speech. And these tend to work really well. Something called delayed auditory feedback, where they put headphones on you and you can hear your voice and you're speaking on a delay. And it's supposed to help with your pacing, it's supposed to help with your fluency, making your speech smoother if you have any kind of little stuttering, and then it's supposed to help make you louder as well. That's a little bit of an older method. We still use it once in a while. We'll pull it out for the right patient. There's amplification systems, so just like what I'm wearing right now, a little microphone, but a personal one that you can use even just if you're at the grocery store or something. This is something that we'll give to like teachers in their classrooms, so you don't need a whole system, but it just amplifies enough that the people around you can hear, and it's a cheaper, more affordable kind of device. And then there's this thing called pitch limiting voice therapy, which is sort of the same thing as that LSVT and the Speak Out, where you want to increase your respiratory support, but this one says that they want you to be using your voice only at a low pitch. So the research has shown that if you're doing some of these therapy techniques, your pitch will go up. And some people don't like that. Your pitch is going to go up if your volume goes up. It's just kind of how our bodies work. So this is specifically targeting getting that volume up without increasing your pitch. So it's another approach to look at. There's a couple of studies to support that it works. And then, I didn't write this on here, but singing, again, group singing, choirs is another nice way to kind of target some of the speech therapy goals that we have in a setting that's a little less formal and a little less drill-based. And it's fun for some people if you like to sing. So the things I've been talking about to this point, research that has been done, has really been done on people more in the moderate stages of Parkinson's disease or even the earlier stages of Parkinson's disease. So what about in the later stages of the disease, if the disease course is such that it really particularly affects your speech? And I would just tell you anecdotally, having done this for 13 years, that's not always the case, really. I mean, it is sometimes, but it's not always the case. But if we get to the point in the disease process where a person is really unable to use their speech as their primary mode of communication, then our job as a speech pathologist is to, as I've written up there, maintain the best communication we possibly can for this person for as long as we possibly can, using whatever means that we need to. Meaning, something like this device here, an alternative communication device, where you press a button and the computer speaks for you. And it can be designed to work for you specifically. You have pictures and names and things in your own life, so it is personalized to you. There are a few companies that make these kinds of devices. You can also get different apps for iPads or Android devices. So there's quite a few options out there, and they're actually getting cheaper, which is really nice. But this is something that we can do if speech becomes not an option for the best communication at some point down the line. The other thing that we would consider at that point then would be bringing your caregiver or your communication partner in and training them in, together with you, in kind of creating your own partnership in communication. Different symbols, different gestures, different whatever, and there's whole programs that we can do for that to help you communicate to a single or a couple of people in a unique way without necessarily fully using speech. So if you do have Parkinson's disease or some sort of Parkinsonian process, what could you do right now to make sure that your speech stays as strong as it is and your voice for as long as possible? And as we know with other pieces of this disease, movement and swallowing and walking and tremor, there's not a whole ton of control that we have, but there are some things we can do to help ourselves. So one thing I would encourage you to do kind of all the time is just check in with yourself. How loud are you speaking? Are people hearing you for the most part? Or are you getting lots of, can you repeat that? And if you are, just try to speak louder. Take a bigger breath and try to speak louder. See how it works. See if you can do it. Just continuing to speak and communicate, I think, is really important. We know that fatigue can set in and using muscles for too long can make them tired, but at the same time, we want you to use these muscles and you should be able to be able to communicate and meet all the needs of your life with your communication skills. Make sure you're using your lungs to their maximum capacity. We spend so much time in speech therapy with people who have Parkinson's disease, basically reteaching them how to breathe, reminding them that they have so much more room to get air in there than they think they do. And this is another kind of part of the disease where it just slowly, you're not taking as big a breaths, or slowly those muscles just aren't engaging quite as much to get big breaths. And you don't realize that there's all this extra space in your lungs you could be using that can be giving you a bigger voice and better articulation, and therefore better understood speech. So take deeper breaths. Think about your breaths. Make sure you're using those full lungs to their full potential. And then, of course, working with your doctor to optimize the timing of medications for the best motor function that you can get. And again, prioritizing, do I want it so that I can swallow best at lunch, or do I want it so I can speak well for this meeting or something else? So really taking your own particular life into account. Okay, so where is the research headed in our world, at least? So I will tell you that, as you may know, in Parkinson's, most of the research is in a lot of the neural pieces, looking at rat models and looking at the cellular and molecular level, the neuronal level. But if we're just looking at therapy, these are some of the things that are going on in the world of speech pathology, and then also, I guess, physical and occupational therapy. But we're looking at what is the optimal frequency, intensity, and duration of therapy. We know that there is such thing as too much of a good thing when it comes to speech therapy for Parkinsonism. We also know that you can't do too little. So what is the right amount, and then over what period of time? It being a progressive illness, how often do we want to be checking back in with patients, and what makes the most sense to preserve function for the longest amount of time? We're looking into group therapy. This is, of course, something that's been driven by reimbursement. But also group therapy seems to work really well, because if there's more people around you, you're going to be inclined to be using more power, to be speaking louder, and that's the first goal for us. So it actually works out pretty well. Teletherapy, so can we be doing therapy if it needs to be intensive? Do we need to bring you into the hospital every day for therapy? Or can we just get on the computer and Skype you and do therapy that way? That might be really good. So we're looking to see right now if that's as effective as in-person therapy. And then we're looking at communication-related quality of life scales to kind of help us figure out what the needs of patients are and how we can best be treating them, instead of just saying, well, the research says this is the best way to do it, so we're going to do it this way, which I think this is a very good thing. So, of course, I have to give the little the information for our clinic, so you're aware if you do feel like you need any kind of assistance. And in the next slide is all of our voice-trained speech pathologists, again at the main hospital. And then I wanted to leave some time for questions. So again, we talked mostly about voice and speech today, but if you have questions, anything speech pathology related, cognition, memory, swallowing, saliva control, I would be happy to talk about that as well.
I'm wondering if moisture has something to do with it. I'll give you an example. I can go in on a Saturday night and take a shower, and I'm stumbling, mumbling, and fumbling going in. Coming out, I feel like I could sing opera.
Well, I think the shower does that to all of us, right? We all want to sing opera in the shower.
More noticeable now.
No, moisture can definitely play a role for some people in the way that their vocal cords are functioning. We want an optimal environment for the vocal cords to be working in, which means the tissues need some amount of moisture. The literature right now is mixed as to what level of moisture is what we need and how much comes from hydration and systemic hydration and how much is just that surface tissue moisture. But we do have a lot of people who say if I'm exposed to humidity, a humidifier, a hot shower that's humid, it does help my vocal folds to work better. And that's not specific just to Parkinsonism. That's kind of every voice.
Do you need to be on or off to do the treatments?
Oh, for the deep brain stimulator? No, doesn't matter. We would probably want to do what you're in the most. So if you're on all the time, then we would want to be doing it while you're on. If you're off, we'd want to be doing it while you're off.
Thank you.
And where you use your communication the most. And incidentally, we have found in the literature that both with medications and with the deep brain stimulator, therapy is more effective when you have those things. Therapy alone isn't quite as effective. But if you have those things, therapy works even better.
I have another one.
Yeah.
I call it the Joe Biden phenomenon. Most of us saw the Democratic debates and saw how he started out real well and then started weakening and mumbling a little bit or stuttering a little bit, and then he stopped suddenly. That was me. My heart went out to him.
Yeah.
And I'm wondering what caused it. That seems to be more cognitive. What is it that you start out pretty good and then pretty soon you don't know what to say or you say something stupid?
Yeah, I think without knowing his case, what his health specifically, I think that has a lot to do with cognitive load and stress.
Yeah, stress.
And so your brain can only handle so much coming at it and being manipulated inside of it all at once. And then you add the stress of being on a national stage and in that situation with time limits and competitiveness and everything else. And I think, especially if you haven't gotten a lot of sleep, if you haven't eaten well, if you haven't taken care of yourself, and if you are a little older, that's going to be even harder. So, yeah.
Yeah, and I'm not saying he has Parkinson's.
No.
But I'm wondering how common it is because my heart went out to him. I'm
Yeah.
feeling that same way when I talk.
Yeah. I think we've all kind of been there, haven't we? I have a 6-month-old and I feel that way because I never get sleep anymore.
But is it a common Parkinson's phenomenon?
It is, yeah. And you see that in Parkinson's with the motor functions too, right? Like you just kind of go, and then it just kind of poops out. Yeah.
I have a question back here.
Do you know of the app? You know of the app that has a meter on it to tell the decibels?
Yeah, there's a few of them out there. And I don't know specifically. I know on my phone, I downloaded whatever one was free, and it works just fine. So I don't have a specific recommendation, but there are apps out there. And, they're not perfectly scientific, but they certainly work for what you need to compare from one time to the next. Yeah. That sounds a little bit more like it's related to something with the swallow. Like you're not getting it down, so it's kind of getting stuck in there. So that might warrant a swallow evaluation, get a peek inside the throat and see what's going on.
So the question was, there was so much saliva that they were almost throwing up, and so that's thus the swallow evaluation. So I just want to make sure people heard that.
Yeah, thank you. We'll wait for the microphone here.
What about the opposite? Dry mouth, dry eyes, the shaking syndrome sort of
Yeah,
thing.
and that could be medication related. That's what we see a lot. So that's worth kind of talking to your doctor about to find out if there's any medications that particularly cause that. There's some things that can moisturize your mouth. Sucking on hard candy can help sometimes just to increase the saliva production, drinking more water if it feels good to you. Also, there's things like Biotene, it's a brand that comes in a toothpaste and in a mouthwash that is supposed to increase the feeling of moisture in your mouth. Some people have really good success with that, some don't, but it often comes down to medications, so it's worth talking to the doctor about.
I would recommend that candy be sugar-free. Sometimes if it's sugary, it makes a lot of saliva and it can become more of a drooling issue at that point. So sugar-free candy and gum can help with that. And we do have something called artificial saliva or Aurabalance that we can prescribe as well. It's kind of like a gel that people can apply with their, like a mouth sponge or even their fingers to the inside of their mouth. Or sometimes they just put it on their tongue and move their tongue around to kind of moisten their mouth. People love it or hate it. It's kind of like they either don't like the texture or, this is great because my mouth has been so dry. So.
And there's something to be said, as we were talking about earlier, for just putting a humidifier next to your bed. Sometimes that feels really good too, to increase the moisture.
I have a problem with phlegm. I will try to start talking and it just garbles up. And I have to, in order to even get my first utterance out, I have to clear my throat, and I have to continue clearing my throat to continue to speak or to talk intelligibly.
That's a frustrating
Is there
problem.
something, is this I have not heard this mentioned much.
Yeah.
And nor have I heard any kind of a therapy or medication for that condition.
Agreed. So I don't know that this is necessarily, again, specific to Parkinson's disease, but the thing about phlegm is it can be related to a number of different things. So what we would need to do for you is figure out what is the actual cause of this phlegm. Is it allergies? Is it post-nasal drip? Is it because something's going on with your swallowing? Is it that there's not a lot of phlegm, but it's just really thick and sticky, and if we thin that phlegm out, it won't be so annoying to you. So the best suggestion I could make would be to talk to a doctor, talk to an ear, nose, and throat doctor. We see patients like this every day who come in with the complaint of phlegm. And we have to kind of work together with colleagues in neurology and in pulmonology and in the allergy team to figure out what that cause is. And it does take some time and some digging, but if we can figure it out, people have pretty good success. No, that's not like the black and white answer I would like to give you, but it's a frustrating problem.
What do you feel is the best website to go out and do research for Parkinson's, whatever?
Yeah, that's a good question. And I was kind of Googling in preparation for this just to sort of see what was out there. So I can't give like a professional recommendation. I can tell you that our website for speech pathology and the American Speech, Language, and Hearing Association has some nice stuff on there, speech specific. As far as Parkinson's in general, I'm not so sure. But I just go into Google Scholar so I can read kind of the latest research articles that are out there.
Yeah, I would say Madison has are you from Madison area? No. Janesville. Okay, so Wisconsin actually has a great public library system. And I would highly recommend kind of getting into that because they can hook up with the medical library up here and get you the latest research. But for kind of lay research discussion, because sometimes you can get a journal article and it kind of sounds Wisconsin Parkinson's Association. Yeah, yeah. And so that's a good one. And then, of course, the Parkinson's Foundation. So, yeah. National. Yeah, the last presentation was actually about where to find information online about that. So, you missed it by one.
Yeah. Wrong expert.
Oh, it's on the website. Yeah. So moving forward, so uwhealth.org/moving forward. If you watch the one from last month, it actually talks about where and how to get the best information on Parkinson's and really any medical disorder.
And I have to say, the UW Health website is pretty comprehensive, and they have some nice links on there as well, just about educational things.
Any other questions?
Just wondering, the therapy is like a lot of work and prayers, you know.
Hopefully I scared you out of it, huh?
No, it's not even me. But I'm just wondering how do people stick with this, or do they kind of give up after a while? I mean, not even just while they're in the therapy, but I mean, this is something you have to keep doing, practicing your techniques, right? So I'm wondering how the stick with itness is.
Yeah, great question. And I would say it's kind of on a person-by-person basis. I would say that's the big weakness of the therapy programs that we have available to us right now, is that what happens in that long term. And you know, the suggestions that some of these programs and some of the research makes is that, well, the speech pathologist should just follow up with them in 6 months and follow up in 6 months and follow up in 6 months. But does that help? You know, how effective is that? Do we need to do a whole other course of therapy? Is that going to be even helpful if we already did that course of therapy? So I would say, you know, most people get through that kind of 20-day or 16-day period. And then as far as the follow-through after that, it's kind of person-dependent. And I mean, I think we know all of us are maybe not the best at following through with some of those things after a while, especially if things are going well. Yeah, there's a question over here.
And just to follow up on that, and then I will come over here because I see there's another question. You know, I find that as Parkinson's is a progressive disease, what you might get out of speech therapy one time may not be the same as what you do another time. So I often send people back to speech therapy or physical therapy or occupational therapy and find that they get something different each time that they go. And it's really us cheerleading you on along the way too, because I think it's an ongoing issue. I know it can be pretty tiring to always be thinking about how you speak, how you walk, how you move, because that's a lot what we teach. But that's, you know, it's not only as you progress, there are different things you can get out of it, but also us kind of, let's do it again. Come on, let's, you know, do it again.
Yeah, and I think, thank you for making that point, Addie. That's a really good point. And I think we would kind of revisit each time, like, what are our goals? Where are we at? What's going on? What are your specific needs right now? And maybe tweak therapy based on that.
So my question is a follow-up to that stick-to-itiveness question. If you do go back for therapy, you know, months, a year or two later, if it's one of the ones, the Lee Silverman or the Speak Out, the sort of really intensive therapies, do you usually go through the whole do people go through the whole program again, or is it kind of refreshers, shortcuts?
We would want to do a full evaluation and kind of see where we were at. And the clinician would kind of make a decision on that. We've had people go through the whole thing again and have really good success with it. We've had people who don't necessarily need that, maybe just like a mini intensive session tune-up kind of thing. Or we have different goals altogether. So it just kind of depends. As Addie pointed out, it's a constantly changing disease course, so we got to kind of reassess where we're at with everything.
Does the therapy that you've spoken about tonight, do you find that that helps with aspiration or choking with eating, or is that a different kind of?
These things specifically do not. Maybe a little bit. Like the Speak Out does talk about how it targets some of the muscles of swallowing. But swallow therapy is kind of a whole different thing. And I kind of purposely didn't touch on that tonight. But there are certainly exercises and different little therapy techniques that can be done depending on what's going on physiologically with the swallow.
Yeah, so you bring up a good point that swallowing muscles, while they're, maybe, used in speech, I guess that's not my knowledge, but it's still a very different process than, the speaking part.
Yeah, I mean, it's a lot of the same muscles, but we would be targeting different things with those muscles. So the therapy is a little bit different.
Any other questions? Okay, then I think we'll conclude for this evening. Thank you.
Thank you.